welcome to today's Media Dialog titled COVID-19, Why We Are Not Past It. I'm Wayne Sharp, Health Media Specialist with the Internews Rooted in Trust project. And Internews is one member of the group hosting this dialogue, the Media Task Force of the Eastern and Southern Africa Interagency Working Group for Risk Communication and Community Engagement. My co-moderator is Tole Nyata, Internews Pandemic Media Mentor based in Zambia. The World Health Organization met to determine if we are finally once and for all past this COVID-19 pandemic. And they concluded that even though there has been a decoupling between COVID infection and severe disease, the coronavirus remains, unfortunately, a global health emergency. As evidence of that, the WHO's Director General noted there have been 170,000 deaths in just the last 8 weeks. Despite this reality check, countries in East and Southern Africa region are letting down their guards against COVID-19. Levels of COVID testing are dropping. The concept of herd immunity is gaining traction once again. And a dangerous subvariant in China is threatening to surge around the world and in the ESAR region, despite efforts made to test travelers. Journalists, meanwhile, are facing the daunting challenge of covering this ongoing pandemic in an environment where COVID fatigue has prompted governments and citizens to let down their guards. So to help us explore these issues today, we're joined by an epidemiologist working with the Emergency Preparedness and Response program at the WHO Regional Office for Africa in Brazzaville, and by a science journalist who will coach us on how to keep developments in the COVID pandemic on the news agenda. I'll remind you now, please, if you have a question for any of our speakers today, please just type it in the text box. And co-moderator Tole will keep an eye on those, and he will ask them of our speakers as we go through our chat today. So feel free to fire away any questions you have. But without any further ado, I'd like to introduce our first speaker. Dr. Opeayo Ogundiran is the epidemiology pillar lead for the regional COVID-19 response at the WHO Regional Office for Africa. He coordinates surveillance for COVID-19 in the 47 Afro member states and provides a regular situation update on the pandemic for the region. Dr. Ogundiran joins us to give us his take on where the epidemic is and why we should continue to monitor and report on it as journalists. Welcome back to the dialogue, Dr. Ogundiran.
Thank you very much, Wayne, and good afternoon, everyone. I think Wayne has given a very good background leading up to the conversations that were held last week with the International Health Regulation Executive Committee. So I'll just quickly share some slides just to help us guide the conversation, not anything too detailed. I'll try not to speak too much from my side today, with the hope that we'll be able to save some more time to have more conversations. So Wayne, please, if you could just help me confirm you can see my screen.
Mm-hmm. Yep, we see your screen.
Okay, fantastic. So just a few points to have conversations around, following from what Wayne has rightfully said. So what does the pandemic look like as of today? So we, especially when we compare the number of cases we're seeing at the beginning of the year, 2023 to the past 3 years, where since we had the COVID-19, we're seeing a comparatively low number of cases and deaths. It's almost unprecedented. The last time we saw this type of number of this low number of cases and deaths were right at the beginning of the pandemic. And that picture is basically painted out because we are not seeing the emergence of a new variant of SARS-CoV-2 virus, which was not the case at the same period for the past 3 years. But having said that, once again, referring to the information shared by the WHODG last week, the Omicron variant continues to evolve. The SARS-CoV-2 virus, now it's the dominant form is in the Omicron variant, and it continues to evolve into different subvariants, sublineages, and recombinants. And recently we saw a surge from two countries in particular, quite a number, but two countries in particular, China and the United States, where the XXB 1.5 in the US and the BQ1 in China caused surges in recent weeks. And having said that, even though it hasn't caused the type of international spread that has characterized the past 3 years, every opportunity that the virus has to be transmitted from person to person gives it a chance to mutate to a more virulent form. Another topic that has been discussed quite a lot in the past few weeks was the surge that was reported in China a few weeks ago, and especially how that surge, how international travel around the China Lunar New Year and the interconnectivity with Africa, what that means for us on the continent. So, like I said previously, the sublineage BXQ was implicated in that surge. At the time, China had switched their policy for control of COVID-19, the zero COVID policy, to so they switched from it. Essentially, what happened was the lockdowns that we saw in many countries in major parts of the beginning of the pandemic continued in China, and the switch of the policy meant there was a large population that were not protected, being exposed to the virus, and because of that, there was a big surge in cases and deaths. But though that surge was concerning, especially due to the interconnectivity with Africa, we are not that worried, and I'm saying that with a lot of caution, because the variant and the subvariant that's circulating in China essentially is circulating majority of the world. So it's somewhat like a delayed surge that happened in China just because of the change in policy, and not because it was the emergence of a new variant, for example. Another major thing to discuss today is testing continues to remain significantly low, and that's both for diagnostic testing and genetic testing, for which we do a genomic surveillance to keep an eye out for what variants or how the virus evolves, essentially. And it continues to remain low, quite understandably, in context of outbreaks or indeed pandemics. Whenever we have a drop in number of cases, we'll also have a commensurate drop in testing for obvious reasons. But having said that, this low amount of testing deprives us of that vigilance, so to speak, for the emergence of anything interestingly new. You know, it could be evolving, it could be recombinant, and that risk, potentiates the possibility of missing the onset of emergence of a new variant or mutation to it, and because of that, there's a chance to miss the opportunity to curb it early. So I guess that's that about testing. Another thing to touch on is long COVID, and this is the long-term, the long-term effects of COVID-19 infection. Essentially, what happens is, in addition to the acute phase severity in respiratory symptoms, a lot of research has shown that some infections with COVID-19 cause long-term sequelae, long-term clinical manifestations beyond the acute infection. And unfortunately, it's not just a respiratory infestation. It could affect any part of the human body, cause long-term. Some people have reported vertigo, continuous feeling of dizziness, others prickly feelings at the sole of the feet, acute drop in blood pressure, and there are many other syndromes that come out of COVID-19. Now, the reason why we're a little bit worried about this is it still remains very poorly understood. And maybe just touch on a few points why. For long COVID, for us to make a diagnosis of long COVID, we have to, by default, have a precursor of a positive COVID-19 infection. And as we know, majority of COVID-19 infections are asymptomatic. So if somebody, say, for example, has got infected with COVID-19, did not do a test, did not show symptoms, but all of a sudden start having problems with blood pressure drops and the likes, we can't particularly identify that as long COVID. The other thing is a lot of people do not even link it. So even though they had an infection with COVID-19, 3 months down the line, they're having some other strange non-respiratory symptom. Reporting that in itself might be an issue. And I mean, that's just to graze the surface of the reasons why it's still poorly understood. Before I move on from long COVID, the reason why I'm spending some time on it is it also has a peculiarity, and it's important for us to continue to have it at the back of our mind, especially with the risk perception for vaccination. Now, long COVID, unfortunately, is not related to severe disease. So somebody could have a mild form of the infection, doesn't end up in a hospital, just has the sniffles and recovers from it, but unfortunately could then have long-term sequelae of the disease. And that's why we keep on pushing the conversation around vaccination, because it's yet another reason to be protected and not get infected, because one does not know what type of presentation one will get if infected with COVID-19. And I guess that's a good way to then move into the last point, herd immunity. So the concept of herd immunity, and I'm sure we all know this, it's been flying quite around, is if a critical mass of a population is immunized, say we usually target above 80%, the pockets of individuals that are not vaccinated amongst that population would, by extension, by cover, so to speak, would be protected from infection of diseases just because of the sheer number of people that have been immunized, so to speak. For COVID-19, what we have is not herd immunity, and we are not going to reach herd immunity because by default, for us to have herd immunity, it has to be conferred by a vaccination attempt. We're not going to talk about herd immunity in a context whereby the natural immunity of a virus is being considered as protected immunity, if you know what I mean. And having said that, if we do look at the coverages in our continent, we are not anywhere close to herd immunity. So that notion that a lot of people have been infected by natural immunity would confer protection on others in the context of herd immunity, I think it's a piece of information that has not been actually understood properly. And the reason why we want to look at natural immunity is, one, it's not been as researched as the immunity conferred by the vaccines as well. It's also been shown that it's not as effective individually as the immunity conferred by vaccines. We still don't know, and I've talked about long COVID. We can't have a virus being perpetuated and us taking benefit of natural immunity, and I mean, by all means saying that that's herd immunity. So those are some major reasons why we would not propagate the concept of herd immunity in the context of an ongoing transmission of a virus, and a virus that can actually cause quite a lot of death in case it switches to something that we have seen in the past with Alpha, Beta, and Delta. Having said that, I think that will be a good point to end my own part of the conversation. And Wayne, I think it will be good to switch to a point where we can then discuss majority of other concerns that come up. So I would leave it at that. Back to you, Wayne.
Thanks very much, Ope, for that presentation. I want to remind people on the call, please, if you have a question, please use the chat box and type your question in, and we will make sure that our speakers get those questions and can answer them to you live. Before we go any further, I'd like to introduce Adele Baleta, Adele is an Internews pandemic mentor. She's an award-winning science writer, editor, facilitator, and media consultant. And she's a vaccine safety communications advisor to the WHO. And she's a member of the South African National Advisory Group on Vaccine Hesitancy. So as we continue to discuss these issues, Adele will also give us hopefully some advice on, as journalists, how we can continue to cover this pandemic that in many ways governments and public health officials are saying, let's move on. But as we know from the reality, even though we're in our fourth year of this COVID pandemic, it's still with us. Adele, do you have any introductory comments you'd like to make to start us off?
Really just some sort of thoughts that I've had. Firstly, that, you know, when we talk about should we still be writing about COVID-19, there are a number of things that have happened, as you have mentioned. First of all, the fact that the WHO has quite unequivocally said that this is still an issue of major concern. And, you know, as journalists, I think if we use WHO as a source, I think we need to take that is it. Okay, it is still an emergency of great concern. Just reporting about that is a great story. It's putting the story back on the agenda according to a World Health body. So I'm just thinking, you know, immediately what starts flooding through my head are kind of story ideas. I really just wanted to say as an opening statement that also, and you know, what we've just heard now in terms of testing, I think testing is a very, very big story. And I think that we're not covering it well enough. You know, I think that I saw somewhere that 120 million rapid antigen tests were given to our continent, okay, via the ACT accelerator. And I was actually quite surprised to hear that. And as a journalist, I'm just thinking, okay, I need to start finding out, where have those rapid tests gone? Are they being used? How are they being used? Did they get to the places that they were supposed to get to? Why is a rapid test important? You know, for a long time in other countries like, say, the States and UK and Europe and Australia, those rapid tests were just par for the course. You could find it in anybody's cupboard, for example. So if you were going out and there was somebody that was concerned about anything, the rapid test came out, boom, then followed by a CPR test, okay, if you've got a positive test. But it's really, really important that we do have access to these tests. And I'm sure Opeayo would be in agreement with me around issues of, you know, sort of people that are immunocompromised needing to have access to rapid tests. If there's an emergency, if there's a surge going on, we need access to rapid tests. They don't replace the CPR test. But 120 million, it would be nice to follow the numbers. I always say, follow the numbers. Get hold of whoever's in your country that deals with rapid tests. And I mean, you know, this is really more of the same, isn't it? It's like in the early days of the pandemic, we had to follow the PPE. Now let's follow the tests. Are they being used? I just wanted to, I hope this is okay, Wayne. I'm just thinking of stories, ideas as they come up. But I was also thinking about the issue around the fact that genomic sequencing is slowing down. Such a valid and such an important point, which means that we're really we're not being able to track the evolution of variants, which means that we can't alert populations. Like, for example, when Omicron came around, you know, Dr. Tulio de Oliveira, who's a South African scientist, was able to put that message out and say, there is this new variant. If we're not able to do that, then we're going to get surges where we're not going to be able to do anything about it. So that's really important. But I thought that maybe because, and this is really because of a story in South Africa, Paxlovid, I think it's an antiviral, and it is a treatment, and it has been, for the first time, it's been given regulatory approval in South Africa. Elsewhere, it has already had approval. But what's important about this, okay, is that antivirals need to be taken 2 to 5 days, and please correct me if I'm wrong, doctor, but I would say, sort of within 2 to 5 days of infection. And, if you don't know that you're infected because you haven't got the test, then that Paxlovid is not going to be working for you at its optimum. So, all of these knock-on effects are great stories to write about. Yeah, so that's all that's come to my mind. And I think I do have others, but let's open it to everybody else. Thank you. Thanks, Wayne.
Thanks, Adele. Yeah, I was thinking of the case with Omicron, and it was identified in South Africa. And I remember that, there was this misconception that, it must have originated in South Africa because that's where they discovered it. But it was because of this rigorous testing regime. And so is that not happening anymore? Is there a reason why that level of testing has stopped in South Africa, or is that are they expecting tests from other parts of the region in order to inform their research?
I think Dr. Opeayo, do you want to answer that question?
Oh yeah, sure. I'll be happy to. So I'll just, once again, not to talk too much, just deal with that. So Wayne, yeah. So it's not. So in South Africa, we continue to test. I mean, South Africa is one of the, and I guess we've lost the number of adjectives we could use to qualify the great work they've done out of there, demonstrated during the time of Omicron. But essentially, globally, what's happening is, and I think Adele mentioned it very well, the number of tests being conducted all around has dropped. And the genomic sequencing usually starts off with a test. So if we know somebody is infected with COVID, we can then take a sample to know what type of DNA essentially we're dealing with. And generally that has reduced. Some people would argue that, well, in the middle of a pandemic whereby we're not having that much of intense infection, we would definitely see a drop in number of cases. Indeed. But then we would also not want to have a drop in tests to the level whereby if something pops up at some remote part of the world, we would miss it. So access to RDTs. Okay, so Wayne, maybe just quickly ask, can I respond to some things that Adele mentioned, or do we just pack on? Okay, sorry, go ahead.
Yeah,
so access to RDTs, bang on. We had a large number of RDTs received on the continent. There are a couple of initiatives that have tried to provide better access, and I'll just touch on one that WHO is doing at the moment. It started during the intense infection of the Delta wave, sometime at the middle of 2021. What we saw then, similar to what we're seeing today, a drop in number of cases. A drop in the number of tests. Testing had reduced quite a bit. The few tests that were being conducted had a very high positivity rate, which meant we were not picking in infections. The few that we did tested positive, and a lot that were not picking, we just were not picking because we were not testing. So what WHO did at the time was to move the whole kind of testing, sitting in a health facility expecting people to come, to a push system, something like what we do with vaccination, routine and supplemental, and then go into communities to offer testing around positive cases. So that project has been rolled out to 14 countries now. And the idea is to move RDT testing right into communities where people can then get tested. So that's one initiative by WHO. There are lots of other initiatives for RDT testing by different organizations, like CDC and many other organizations trying to push that forward. Points about genomic surveillance and testing, I think you are spot on. We will not be able to treat if we don't know people are sick, and even if we have the best countermeasures, therapeutics, if we don't know people have not tested positive, we probably will not be able to start treatment on them. So I'll just leave it at that. Back to you, Wayne, and thank you very much, Adele. It was amazing.
Thank you both. Tole, I believe we have questions in the chat box. Could you take care of those?
Yes, we have Michael Guarisa, who's asking, with the pandemic fatigue that has kicked in at a global stage, how can a journalist package the COVID story in a manner that can get the audiences to pay attention to the COVID story? I think this goes to Adele. Adele?
That's a great question. And it's a question that I keep on asking myself, because as you know, I'm a journalist. So I also need to ferret and find stories and package them and keep my the people that I write for interested. And it's not easy. It's not easy because, you know, we all live in a world where there's a lot of clickbait. We live in a world of social media, and we're living in a world where the worst news is going to be at the top of the agenda. And that's not always a useful thing, if I may say. So for me, I think what really becomes important is it's not really about breaking stories anymore. It's really about looking at the longer form of journalism. It's looking at unpacking really, really important issues. So one of the packages that I would suggest, starting right off from now, okay, and I am going to ask one of my colleagues, although I might do it later, is to put in, please, that guidance document where we actually go through a number of stories that you can start looking at. We say that there is pandemic fatigue. We say people don't seem to be interested anymore. And I think that really what's important is to have a look at these story ideas, and we'll drop the guidance in the chat. But let's look at this now. Let's try and work with what we've got. And what we have with us is a great WHO epidemiologist, okay, who's sitting right there. I can see him in the chat, right? He's a participant. And what he's told us is really quite fascinating. There are 3 different areas that he's already spoken about that could have packages of their own. The one is about COVID-19. The other one was the issue around herd immunity. And the other one is around testing. If you think about that, there are 3 fabulous areas where you can start writing stories about that. So let me take, for example, something like testing. And I really would love other people to chime in and tell me what your ideas are as you are thinking, you know, while we're chatting. And I was thinking one of the things are, okay, you told us, okay, what WHO's approach has been to the 120 million rapid tests that have been now taken into community, as you have explained. For me, that's a great story. I would personally want to know if that's happened in Zambia or in South Africa or wherever the case may be. If it's not happening, I'd like to know why it's not happening. Why don't we have rapid tests? That is a story in and of itself. One of the things that could be done to actually deepen the story, to give the story some richness, is to actually go out with teams to look at the rapid test being employed in those communities. So why is that important? It's important because it is really opening up people's acceptance, right, of the newly accessible things that make a difference to people's lives in terms of COVID-19. But it's more than that. It's also about strengthening health systems. It's about delivering healthcare. So, you know, if we start shifting our focus just a little bit and start thinking, okay, so this is the story that I can see. It might be a bit boring, like 120 rapid tests. So what, who cares? Maybe we've only got 50 in our country. That's not the point. The point is that what is actually happening on the ground? Okay, what difference is it going to make? And then you ask the question, okay, so why the rapid tests? Okay, and then we can start talking about things like the importance of an important thing for a rapid test is around, okay, I don't know, Doc, you can probably help me with this, but I know that it's around immunocompromised people and getting, you know, in the middle of a surge, for example, and we need those rapid tests. But what it does is it puts testing back on the table. And why is that important? It puts testing back on the table because we need to be ahead of the variants, okay? Because we don't want to have a surge in variants. We can go back to the point that the WHO has said it's still an issue of concern. So can you see that sort of structuring of an article? It becomes like, well, why are we talking about this anyway? Because it's still something of concern. We can even use the Chinese thing as an example of how things can happen. Yes, it was a policy thing, but the point is that there was a surge there. So the other thing that I would also then maybe introduce is the fact that what about antiretrovirals? It's important to get testing because of what I explained about Paxlovid. There's also maybe another angle to a story like this, and still bearing in mind, we're still staying with testing. Okay, we haven't even looked at COVID-19 as a possible story. We haven't even looked at the whole issue around herd immunity, okay, which is just, by the way, is essential. That herd immunity mix-up is so important because that is being driven by anti-vaccination groups or people that don't believe in vaccine to turn people away from vaccination. So that is something that if you don't understand exactly what we're talking about here, you need to get a handle on it. It's very important because otherwise you're not going to be able to debunk what people are saying about herd immunity. But before I go there, I want to come back to that point. What I wanted to also say is that in sort of like looking around for little stories around testing, it's also been very interesting to me to see that I think the WHO is behind this. You can correct me if I'm wrong, but that testing where it's happening is now being incorporated into regular health services. So in other words, if you go for a TB test, you can get a COVID test as well. And in fact, I saw the story on WHO site about somebody that went and got a TB test and decided, oh, might as well get a COVID-19 test on here. Maybe was encouraged for health workers to get a COVID-19 test and found out that they were actually COVID positive. So, that's also a nice story to find out. To what extent is COVID-19 testing being incorporated into regular health services? Very important. So I think that that's another story that could be told. Just coming back to, if I may, to the issue around herd immunity. This herd immunity issue, do you know, even for me, after so many years of reporting around vaccines and herd immunity and, sort of vaccine-derived herd immunity, what the difference between natural immunity and vaccine-derived immunity. Okay, I can still get my head can get into a little bit of a flummox when somebody says, yeah, but if you have so many people are getting infected there. We have a situation in South Africa where right in the early days of the pandemic, there were a lot of people that we found out in retrospect who actually had been infected. This was before they even got to the point of testing. We found out that we actually had a serious amount of people that had been infected, and many of them didn't die. Okay, so if you put that together with the fact that, okay, well, why should I bother to get vaccinated? It's confusing for people, and if journalists, we do get confused. So when you see something around misconceptions around immunity, check it again. Look it up. There's a course, Let's Talk Vaccine course, and it deals with this really, really well as well. So I just wanted to put that in as well. Okay.
Thanks, Adele. Yeah, thank you very much. We have more questions, but I'll just like to give Dr. Opeayo a chance to respond to what you said. Opeayo, if you have any comments further to what Adele has said, please go ahead.
I'll just touch on the issue of herd immunity because I see it popping quite a bit in the chat. But having said that, Adele, I think you brought it together perfectly. And I like the term you used. I'm just trying to quickly quote what somebody had said. It's not about breaking stories anymore. I think COVID we've had it we're running into the fourth year at this point in time. So it's not breaking, but it's how do we then become innovative around the stories. And great job to the team bringing reporters and scientists together. And I think by the time we share those ideas, we could then come up with useful stories that we'll be able to sell. I'll just touch on herd immunity briefly, and I'll be happy to hear a little bit more from journalists. It's really confusing, like Adele rightfully put it, especially when it's being discussed out there in the context of persons who do not see this coverage as being protective, so to speak. So what I would use to explain it a little bit better is to use polio, the polio virus, which indeed confers herd immunity, and then contrast that with COVID. And I think that might make it a little bit more understandable. So looking at the the polio vaccine itself, the oral polio vaccine, this is a vaccine that confers, if a child less than 1 year of age gets 4 doses of the oral polio vaccine, it confers a 99% protection for futuristic infection, which means it's almost impossible for that child to get paralysis from polio anymore. I'll just be doing contrast. For the COVID-19 vaccine, it does not confer protection for infections. So it's a completely different outlook. What the COVID-19 vaccines do is to reduce the likelihood of developing severe disease and death. And that's why you'd see some people who have received the COVID vaccine, have received boosters, but they could still get infected with COVID-19. So big contrast. Secondly, the polio virus, sorry, I keep meddling viruses and vaccines. The oral polio vaccine has had the whole of a program to roll out eradication status or eradication level coverage, which means in countries, the big target is to have a minimum of 80%. And this has been backed by funding by the Gates Foundation, the Rotary, Lions Club, a lot of partners over years, and have raised that. A couple of years ago in the 70s, there were over 350 countries endemic for polio. As of today, we have only 2, Afghanistan and Pakistan. It's a big push for an effective vaccine that confers immunity on a population that would not be reinfected. We don't have that with COVID. Like it was rightfully said, at the beginning of the pandemic, a lot of people, like in South Africa, got infected with SARS-CoV-2. These same people have received vaccines, probably multiple infections. But as of 2 weeks ago, when you compare the number of cases reported that week to the previous week, though it's really low when we compare to previous times, it was an increase. There was a tiny surge in South Africa. And that's in a population that we would have said has been exposed to the virus. So we are not getting herd immunity in COVID-19. I think we can state it clearly. Even in contexts where we have very high vaccination, Mauritius, Seychelles, for example, in our continent, we still have infections being reported for these reasons. The vaccine is not designed to stop people from getting infected. It's just changing that outlook of beginning of pandemic where one gets infected with SARS-CoV-2 and ends up on oxygen versus not. So people could still get it, but they are not going to come. We're not going to scream for some ICU admission and the likes. So I hope that clarifies it a bit, comparing it to a vaccine that confers herd immunity versus what we're dealing with today as COVID-19 vaccine. Over.
Excellent. Thanks so much, Ope. I want to get to Catherine's question in the chat. I think you've already addressed it, but she's asking if there are any countries that have achieved herd immunity. I think the answer is no. Is that right?
Yeah, unequivocally, I would say no, and for those reasons. We have, so once again, to clarify that, because I think it's a brilliant question. Do we have a list of countries that have reached immunization coverage that could have provided herd immunity if our vaccines were that effective? Yes, there are countries that have attained 80%, but because of the design of the vaccine, even that 80% would not curb further infection down the line. We're also dealing with a virus that is, I'm sorry, I should have added this. We're dealing with a virus that's replicating really fast. The polio virus was polio virus type 1, 2, and 3, essentially 3. We've lost count of the number of sublineages of Omicron as one, mutation group, so to speak. So this is a virus that's still being transmitted. The science tends towards it's not going to worsen, but biologically we cannot say. It could transform to a form whereby we do have evasion of immunity and therapeutics that we know as of today. That's why we would not talk about herd immunity in this context.
Understood. We have a question from Beatrice. I think for both of our speakers can address this. Stories related to COVID-19 is not an issue anymore in South Sudan. So what method do you think journalists should use to report on COVID-19? And can you get positive impact or reaction from the people?
Okay.
What do you think?
Do you want to go first, Doc?
Okay, sure. So in context where we've had this level of, I would still use the word fatigue. What we have been able to bring to the forefront is the issue of long COVID. We're not seeing severe disease. COVID is not as scary as it used to be. We're not seeing pictures of those ICU beds packed and we have to give oxygen to people on the floors in the corridors and like, it's the reality. And I don't think there's any use trying to debate that. The risk perception has dropped significantly. But what we are not seeing, which is hidden, it's real, it's hidden, is the long-term effects of COVID. And just by default, like I said, trying to understand how do we even start to quantify it, it's a big problem. And I think that part about, even though you're not getting severe disease today, you could end up with some hypotension crisis, or you could end up with vertigo. You probably will not be able to drive anymore, you know. You could end up with premature abortions, for example. So that potential of peeping into that tiny people of the people that we know that have long COVID and understanding that it's scary if we then amplify to what we do not know about long COVID. And I think thinking about it from that perspective, we might be able to get a story out of it, because it would have been a little bit more explanatory if people who got long COVID were people who had severe disease. Then we would say, okay, we're a little bit protected. But no, I mean, even asymptomatics would come down with long COVID, and that's where it gets scary.
Yeah, no, absolutely fantastic. I completely concur with you. It's such a huge story. It's also fascinating in that we don't have scientific answers for it yet. So there's a whole area. And for those of you that are involved in science writing, you know, I mean, and health is part of science writing. It's a story to follow. It's a story to follow because, you know, you might think that there's no, it's a story to follow because, you know, coming from South Sudan, do you know if somebody's suffering from long COVID? That's the question. As you say, Doc, it's a hidden issue. Okay, so people might be an upsurge in certain symptoms and stuff like that related to COVID-19, and people don't know that it's related to COVID-19. In fact, scientists are trying to make the link. So it's a whole area that's really, really important. And yeah, I would urge you as a journalist to keep your ears and eyes open, nose to the ground, sniff around and find out from friends, from family, or is there anybody that's actually, you know, experiencing really weird symptoms? Okay, I, in fact, just prior to coming onto this, was asked a question about somebody who's really suffering terrible fatigue, and is there a doctor that is known that the person can be sent to? Okay, so it's those kinds of things where you switch on as a journalist. You never switch off as a journalist. It's those antennas should be going all the time. And one should be asking oneself the question, well, why are there more people that seem to be tired? Why are people losing their jobs because they are so tired? But the other stories that you can also do, you know, is just, I'm thinking now a little bit about HIV. HIV, oh my word, it's been going on for decades, right? Do you know that there are journalists that have been following the story through the decades, just following it consistently, looking at numbers, looking at changes in treatment, and it's actually quite phenomenal because those journalists are giving information all the time to their community, okay? It could be about treatment, the changes in treatment. And so I don't think in any way that COVID could have fallen off the table, even for South Sudan. And I think that we mustn't assume that our stories are not being read or that people are not seeking information. For me, I'm going to throw it back to a journalist. It's all about you. It's all about the sources that you use. It's all about how well you put the story across. It's about how you get the attention of your reader or your listener or your viewer. So it's really about also thinking outside of the pack. When you think outside of the pack, it's an amazing thing as to how things happen. Many people, many journalists leave a story because they think, it's over. Nobody's doing it. Nobody's following it. Nobody's harassing me because it appeared in the Daily Mail and I haven't got it. And now I'm being sent out to get it because the Daily Mail had it. The journalist that is really a prize journalist is one that answers questions outside of that. Okay, so keep an eye on it. Look at the various dashboards. WHO has got a COVID-19 dashboard. I don't know, maybe somebody can put that link in for us. In fact, in that document that's inside the chat, you'll find a link to our World in Data, as well as the COVID-19 dashboard. You can see information for your own country. You can see if numbers are going up, if numbers are going down. But the thing is to ask those who, what, why, when, and so what. You know, if you're bored and you sit in your office and you don't have a story, just go revisit, have a look, ask some interesting questions. Phone Dr. Opeayo.
Opeayo has his hand up, and Tole has a question as well, but Opeayo, go ahead.
Okay, if I could just quickly take it. So looking at the chat, to respond to Michael Guarisa's question, I think particularly interesting, but so I'll touch on that. So essentially, yes, that's what I'm saying. Reaching that high immunization coverage would not attain herd immunity because of the reasons I've spoken about. But tying into what Adele just rightfully said, maybe another big reason why we need to keep on covering these stories is for us to push this information out. And that's where the immense impact journalists can make. I think that's where it stands. So I hope today at the end of this conversation, we would be clear on what herd immunity is, what herd immunity is not. But the thing is, I don't know, 30, 50 people having a conversation today is not enough for us to make that impact. And that's where journalists come in. It's about telling the story. It's about, so this thing about herd immunity, we listen to this epi from WHO, and it's clearer to me. How do I make this clearer to other people? You know, and I think that's yet again another reason. The pandemic came with a lot of infodemic and a lot of misinfodemic, and a lot of it is still out there. So in addition to the science in itself, just putting out the right, answering questions, and sometimes they're very fundamental questions. Like we've spoken today about long COVID, about testing. Why are we not testing? If somebody showed up to my doorstep with an antigen test, should I take it? Where do I get the information about it? So that type of information, I think it's yet another reason why we still need to tell these stories, because in the absence, and I'm not a media person, I'm sure I could even get lectured by anybody in the room. The absence of these type of stories gives the opportunity for misinformation to spread out there. So once again, I guess that'll be another reason to keep on telling the story.
You're a communication pro, Doc.
Thank you.
Yes. So there's a question. Someone's asking, after how long can you get reinfected? If you got the first infection, how long does it take for your body to protect you from reinfection? So
I guess the easy or lazy way to answer that would be it depends. What we know as of today with the vaccines, the early studies of the immunity confirmed by the vaccine showed that after 6 months, there is a waning of protection. Now, it doesn't wane to zero, so it takes a period of time where it wanes. But having said that, with co-infection, so natural infection and vaccination, immunity conferred by vaccination. So we call that double immunity hybrid infection has shown to last much longer than that, beyond 9 months. The only clause I would say to that is for the version or the variant of the SARS-CoV-2 virus that we know as of today. So when are we really worried about it? We would say beyond 6 months. If you've not received the vaccine, within 6 months, then you should probably get a booster. The only other thing I'll quickly add to that, because once again, this story about putting out the right information out there versus misinformation. The next question that usually comes up is, so why is it that somebody who got a vaccination 3 months ago tested positive for COVID today? And the answer to that, once again, is the vaccines are not designed to prevent infection. They are designed to prevent development of severe disease and death. So I think it's important to add that just in case that needs to be answered as well.
I'm seeing Dr. Jaya has a comment here. And she says long COVID seems to happen to many people who have mild symptoms, and emerging data suggests it affects the heart in a variety of ways. It's worrying that this hidden epidemic is not being better investigated. How can we tell this story, Adele?
Okay, so again, how can I tell that story? I have tried to tell the story actually. And the last time I wrote about it, I really did write it from a science point of view, in that I was actually putting out the various ways that science is investigating the issue. And, it's looking at the different streams and the different focus. And why I wanted to do that is because I wanted to illustrate that science is not yet agreed. Okay, there's no sort of absolute agreement on the whole issue about long COVID. It seems to be various systems of the body are affected. So the immune system, and yes, the heart system, and I can't remember the other one now, it's just gone out of my head. Yeah, what do you call it, vascular system as well. So and the reason for that was to put out to everybody that, because there's so much misinformation again around heart, okay, and the whole issue around Pfizer, for example, and the misinformation around Pfizer causing heart disease and so on. But the reason for that was really to show that at this point in time, again, there are no absolute answers. These systems are the ones that seem to be involved. This is what the research is saying in this area, in the other area. So I don't think that when you say the hidden epidemic is not being better investigated, I'm not sure that science is not investigating. I think there's a lot of research that's going into this. So it is being investigated from a scientific point of view. I don't think enough's being written about it from a journalism point of view, where journalists are putting out these kinds of questions in a responsible way, right? Where we are being able to give the kind of information that Dr. Ope speaks about, okay, in terms of where people need to go. If they have these kinds of symptoms, what should they be doing? I don't think enough of that is out there. And it worries me a little bit that, when the whole issue around long COVID came up, it was very much like chronic fatigue syndrome, where poor people, people were going to medical doctors and saying, but there's something wrong with me. There really is. And they would say, well, go away and rest, you're going to be fine, and so on. It's now being taken very seriously because of the number of cases, okay, that are being affected. So I think that we need to carry on, and Dr. Ope already put that as one of his areas. We had herd immunity, we had testing. So let's talk about the long COVID. I think we do need to be writing stories about this. And I do think that there's a dearth. There's not enough story writing on COVID, on long COVID in South Africa, actually. Sorry, on the African continent. I don't think we're getting enough information on it to people, because I don't think it's being recognized in communities. That's why I'm saying is that I think that we need to start asking that question in our own communities, even regionally. Let's ask WHO if they're aware of long COVID cases. Are we seeing a rise in particular symptoms? It's a fantastic story and it needs to be written. Absolutely. That's my answer.
Thanks so much, Adele. We've been doing our dialogues for a couple of years now, and we often like to ask the participants, are we going in the right direction? What should we be doing in future dialogues? So we do have a short poll that we would like our participants to answer. I'll hand that over to Christoph. Can you put that poll up there for us? There you go. So if you could just take a minute to answer this poll for us, it gives us some guidance in how we can move forward. We are almost out of time. I wanted to, I guess, open a whole new can of worms and mention that the United States has determined that COVID has moved from pandemic to endemic. And I wanted to ask, what does that mean? And what challenges does that pose for journalists who are still trying to cover COVID-19 as a dangerous disease? But if there's a really, really short answer from Dr. Ope or from Adele, please answer now.
I'd love to hear what Dr. Ope thinks.
My biggest challenge is how to make the answer short.
Yes.
But I guess once again, it leads to information. The declaration of a pandemic or not does not fall within the purview of a country. I think we can state that, and it's for many reasons. Once again, struggling with the short answer. But the declaration of a pandemic has been delegated to the Director General of the WHO. So the ending of a pandemic would need to come out of the Director General of the WHO. Now, it's not a unilateral decision. It's not something he feels. Like today I wake up and I'm like, yeah, pandemic over. Because it's also a consultation. The first consultation would be the IHR Emergency Committee, which sat last week. And these are scientists from all over the world, understanding the data, understanding the status, and then they advise the DG. So he's not going to come out with a statement of his own personal volition, but it's advice based on science. I think I'll leave it at that so that we don't stretch it beyond that. But the important thing is the declaration or not of a pandemic has been delegated to the DG. And maybe subsequently, if, say, for example, the poll says we should talk more about COVID-19, I think another big buzzword that's been thrown out quite a lot is endemicity of COVID-19, which I think once again might need to be unpacked in future dialogue. I'll leave it at that, Wayne, so that Adele could also weigh in.
Well, being a journalist, I'm a skeptic, and I just, I'm so glad, Doctor, that you covered that. I'm just looking up here, it's what does endemic mean in the first place? Okay, so it's actually when in a specific population, an infection is constantly maintained at a baseline level. Okay, so it's sort of bubbling on the back burner. It's not that they're major surges, it's around. So I think that's important to note. But why do I say that I'm skeptical? Because I wonder to what extent that's a political decision, and I might be completely wrong. But, I just wonder how that impacts on, sort of responses to COVID-19, how it works with politics and misinformation and the driving of using COVID-19 as a battling ram in Congress or in, I don't know. I'm just curious about that. I would like to know more about why they've decided that it should be declared an endemic. It should be declared endemic. So that's all I have to say. I would like to read further, basically. There's something else in a question for Dr.
Oh, there's a question?
Yeah.
Also, it says, if natural immunity can keep someone from COVID-19, then why do we need to take vaccine? So for a few reasons. One, the level of protection of natural immunity has not been as well researched. So we can't, for example, say if you've been infected 3 times, you get a 50% chance or a 50% less chance, So that type of studies will usually be done on vaccination conferred immunity. Do we have a certain level of immunity that's protected from natural? I think yes, by all means, we do. The problem with it the next problems are then linked to ethical issues. Can we ethically say we would be happy to let a virus continue to propagate in populations just because of the benefit of immunity. We can't say that for the many reasons we've spoken about today. As it's passing from person to person, it has every possibility to mutate into something we probably will not be able to handle. Even if we're dealing with the virus that we know as of today, we've talked about long COVID, we've talked about the possibility of severe disease. So because of that, those are some of the reasons why that natural level immunity would not be the mainstay of protection. And we can't in good faith say that the immunity by natural causes would then be a big replacement for immunity conferred by vaccines. So GB, I hope that clarifies. Otherwise, well, I'm happy to discuss further if it doesn't.
Yes, sorry, I dropped out for a minute there. I had some technical difficulties, but I'm back. And I think we have reached the end of our time today. I'd like to thank our speakers, Dr. Ogundiran and Adele Baleta, for a very fascinating talk. I'll just remind all participants that we have recorded this dialogue and we will be sharing a link to this recording. And also we will be taking some audio excerpts from the speakers, and we'll be sharing those via our WhatsApp network so that journalists can have some quotes to use with the stories they write on this subject. Please let us know what you think of our dialogues. I'm happy that people answered the poll today, so that'll give us some good material to work on for next time. And until next time, I'm Wayne Sharp on behalf of the RCCE ESAR Working Group and Tole Niata, my co-moderator. Thank you all for joining us today. And until next time, so long.
Thank you, Wayne.
Bye-bye.
Thank you, everybody. Bye.
Bye-bye, everybody.